The aorta by no means is a trivial structure. We can see a number of pathologies, as you can see here in the CT image. We have calcifications and even an ulceration. But what is even more important, even though CT is able to visualize the entire aorta, the pathology, especially in this patient, should also be visible with transthoracic echocardiography. So, transthoracic echocardiography also plays an important role. And this will be the topic of this chapter. Imagine you perform abdomen sonography and you would not describe, for example, the gallbladder. The same is true for the aorta and echocardiography. I believe that the aorta should be described in every report. We can measure it and we can see pathologies. But first we'll have to look to see which parts of the aorta we can actually visualize and how we best visualize the aorta. Transthoracic echocardiography is by far not the only imaging modality we can use to image the aorta. As a matter of fact, other imaging modalities such as MRI or CT are much better with respect to the quality of visualization. Nevertheless, it would be a waste if we don't look at the aorta with the help of transthoracic echocardiography because we can visualize it and because we can detect pathologies. So let's take a look at how we can see the aorta with the help of transthoracic echocardiography. Let's turn first to the ascending aorta. The ascending aorta is best visualized probably from a parasternal approach, both in a long axis view and a short axis view. But we can also see it with the help of an apical view, for example, the 3-chamber view or a 5-chamber view. The problem, however, is we only see the proximal portions of the ascending aorta. This is a major limitation. So here's a parasternal long axis view which shows you the aorta. We can see the valve, the sinus, and also the sinotubular junction, but not very much of the ascending aorta. However, there is a trick. I will show you later in a demonstration. If you move the transducer further upwards, you can also visualize more of the ascending aorta. The next section of the aorta we can visualize is the aortic arch. To do that, we have to use a suprasternal window. You probably remember from the chapter on how to image. What we see here is we see a small portion of the ascending aorta and also the descending aorta and of course the aortic arch, where it is also possible to visualize the large vessels which arise from the aortic arch. Here's such an example. You can nicely see the aortic arch and the descending part of the aorta. The quality you see here is probably what you can get in approximately 70% of patients. Usually it is more difficult to get good image quality in elderly patients. Even though we tend to focus on the ascending aorta with TTE, I would like to point your attention also to the fact that especially from an apical approach, we can also see the descending aorta. For example, we see the descending aorta here, lateral to the left atrium, and also in a longitudinal view right behind the 2-chamber view. What we see is this portion here. These image loops summarize where we can see the descending aorta. In a parasternal long axis view, right here below the left atrium. In a 4-chamber view, lateral to the left atrium here. In a subcostal view, we see the descending aorta. We actually see the abdominal aorta already. And here, in an apical 2-chamber view, we see a more cranial portion of the ascending aorta. Now, this is certainly not an abdominal ultrasound course, but keep in mind that if you move the transducer towards the abdomen, you can nicely see the portions of the aorta which lie below the diaphragm. As you will see in the following demonstration, it does not really take a lot of time to visualize the segments of the aorta. So these are the segments of the aorta that you can see from transthoracic echocardiography. First, parasternal long axis view. We have the aorta here, the aortic valve plane, the aortic root, the sinotubular junction, and the ascending aorta, which can be seen nicer if you, or at least more in its cranial portions, if you move the transducer towards the sternum. Those are the more cranial portions. Then let's move to the apical view. In the apical view, we have the aorta right here beside the left atrium. And if we go to a 2-chamber view
and tilt the transducer, we can see that the descending aorta is visible also here very nicely. And the third view, or the third window, which is also good, is the suprasternal window. Ganz kurz einmal nur am Rücken legen nochmal. Genau. Kopf ganz überstrecken. Okay. And so what we see from the suprasternal window is we have the aortic arch and the descending aorta. Unfortunately, he is not really good to image from a suprasternal window, but this would be the ascending aorta, the aortic arch, and the descending parts of the aorta. So we can see several segments from a transthoracic approach.
This slide summarizes the portions of the aorta we can see. The ascending aorta, which is the portion which is probably best visualized with transthoracic echo. The aortic arch. Then we have a blind spot here. And then the descending aorta, which at least allows us to assess the size of the aorta. If you want to see more of the aorta, but you still want to stick to echocardiography, you have to use transesophageal echo. Transesophageal echo has a number of advantages. Because you're very close to the aorta with the transducer, you have a much better resolution and you can actually see more segments. Still, even with transesophageal echo, we have a problem. Still, the image quality of the distal portions of the ascending aorta is not ideal, simply because we have the bronchus in the way. Compared to transthoracic echo, however, we can see much more segments, as you can see from these two images here. One thing we should always do, ideally in all patients, is to measure the size of the aorta. This scheme shows you where I prefer to measure. First of all, at the aortic annulus, then at the sinus of Valsalva, the sinotubular junction, the ascending aorta, then the aortic arch from a suprasternal approach, and then finally, if it is possible, also at least the proximal portions of the descending aorta. This allows us not only to compare measurements in one patient from one exam to the next, but also to fully describe the shape of the aorta. As always in echocardiography, we should use the so-called leading edge technique. This means we measure the front of the aorta, the lumen, and then the front of the posterior contour of the aorta. So we're only measuring the wall once. Even though the wall of the aorta is fairly thin, and it probably does not make much of a difference, I would recommend you to use this technique. Under ideal circumstances, no matter if you measure in a short axis or a long axis view, you should probably get the same diameter for the aorta. However, this is not always true, and studies have shown that there is a discrepancy, simply because often you tend to angulate in such a way that you hit the aorta oblique, and therefore you get a different diameter, which is usually larger for the short axis compared to the long axis. However, if you see that the aorta is dilated in the way shown in this diagram, so in a longitudinal direction, then you should use the short axis view, because you could miss that in a long axis. One thing to consider, the aorta changes its size. It is a pulsatile structure, and it is slightly larger during systole. Here's an example how to measure. These are two image loops, one showing more the proximal portion of the aorta, and one more the distal portions. You do not have to measure the entire aorta in one loop. You can of course switch image position to optimize the view to visualize the segment that you want to measure best. Here are the imaging points. The aortic valve is open, so we have systole, and first I am measuring right at the origin of the aortic valve. This measurement is important, especially nowadays in the times of percutaneous aortic valve implantation, because we need this measurement to size the prosthesis. This is the measurement of the aortic root, and here we have the sinotubular junction, which is sometimes very difficult to define, especially if patients have an aneurysm. And then I switch the imaging transducer position to visualize more the cranial portion of the ascending aorta, and then measure here, or where I find the aorta to have its largest width. In all patients who have an aneurysm, I also image the aortic arch to see if the aneurysm extends into the aortic arch. And the measurement I perform is shown here. So in conclusion, you can see that you can visualize the aorta with the help of the standard views and maybe using a few tricks. If you measure, all you have to do is look at the ascending aorta. If you have a pathology there, then of course you have to also look at the other segments. And if you have discrepancies between transthoracic echo and other imaging modalities, these can be explained by the fact that, first of all, we are using the leading edge method, and because sometimes the aorta is measured tangentially, and also because a different segment might be measured with the help of CT, a segment which is not visible to you with the help of echo.